We forgot. So you're gonna work on it.
Oh, better be good. Do you have?
I'm just on.
Are you? Did we start with the second one? Okay.
Yeah.
For the video. How do you want to log into the video on here so that way we can? I'm trying to figure out how to get.
So that people watching it recorded can see it.
Yeah. I guess no. Well, we can just send the link out to it.
Okay.
Right.
Yeah.
Okay. Can you? But they need the code from the book, I think, to be able to get it. Right.
Or can your phone just face the screen?
Yeah.
Will that work?
Yeah. Yeah, I think that would work. I mean, it won't be the best quality, but okay, whatever. I mean, we don't have anyone right now, so we're just
Okay, just us.
we're just recording. Yeah.
Did you ever hear back from Gabe? Did you email him the thing?
I did email him the
He
thing.
never texted me back, which is not unlike him.
Okay.
That doesn't mean anything. Welcome, guys. I think we'll get started. The cafeteria forgot our coffee, so they'll bring it here shortly. Or I guess one of us has to go get it in 5 minutes. So, do you guys have any questions from last week? Anything burning? Nothing? Okay. So tonight we're going to talk more about like labor itself and the delivery of the baby. And then if our anesthesiologist decides to respond to my text message, he'll probably log on and talk a little bit more about epidurals. And if not, I'll just talk about them. And then we'll talk a lot about like pain management and kind of the procedures that go on while you're actually having the baby. And then a lot about positioning and non-pharmacologic ways to manage pain during labor. Does that sound good? And then next week will be breastfeeding. And then the 4th week is newborn care and postpartum care for moms. Okay. So we'll get started. So I love this quote. We have a secret in our culture, and it's not that birth is painful. It's that women are strong. And that is so true. Like our bodies were made to do this, and women have been doing this for thousands and thousands of years. And like one mom said to me, like, I feel like such a badass after I push a baby out. Like it's such an empowering feeling, no matter how that baby is delivered. Like just to think about like, oh my gosh, like not only did my body create this baby and grow this baby, but now I just delivered this baby. And then if you choose to breastfeed, like then your body feeds that baby for a year. So it's pretty amazing what our bodies are capable of doing. So just a quick overview of the stages of labor. So stage 1 is dilation, 0 to 10 centimeters, right? So we talked about that quite a bit last week. So that's the process of your cervix going from 0 centimeters, right? There's 1 centimeter all the way to 10 centimeters. And I think Annika was sure to show it to me. I can't seem to make that work, but just to review last week, it's that first contraction until you're fully dilated. So those of you that have Dr. Gallagher for your doctor, he will tell you that early stage of labor, which it used to be 0 to 4 centimeters, and the new definition is 0 to 6 centimeters. That's what we call early or latent stage labor, and that can take 2 hours, 2 days, or 2 weeks. And so that's why when people come into the hospital and they're 1 centimeter dilated, we're like, we don't really want to look at you for the next 2 weeks. So we're going to send you home and you come back when you're in more active labor. Your water could break. Yeah. Nope. So if your water breaks, then it's kind of like the time starts and it's like, we really would like to get that baby out in the next 24 hours. But there are women walking around in the community, you know, that might be 4 or 5 centimeters dilated, but that doesn't mean that you're going to have the baby. You know, I think sometimes the worst thing a doctor does, and I think one of the reasons that they quit doing it is it used to be once you got to 36 weeks, they started checking your cervix every week. I've talked to a lot of people that they like check their cervix at 36 weeks and they said, oh, you're 3 centimeters dilated. And like the mom is like, oh my gosh, like they call up their family, they get them on the phone, like, you better get here, I'm 3 centimeters. And then everybody sits around for the next 2 weeks just looking at each other, because just because you're 3 centimeters, like, doesn't mean it's going to happen tonight. And the opposite is true. Even if your cervix is still completely closed, you could walk out of the office and your water could break and you could have a baby in 24 hours, you know? So just checking your cervix at the doctor's office doesn't buy you much useful information. And so for that reason, they've kind of quit doing that. So that early stage is the easiest generally. The contractions are spread further apart, but it also takes the longest. So if you can, I would encourage you to stay at home, you know, as long as you can in that early stage of labor. Like if your water has already broke, that's kind of a different thing. That's kind of like, okay, my water broke, I should probably head to the hospital. But if you just start contracting, but your water hasn't broke, I would encourage you to stay at home. I would encourage you to walk, to take a nap, to just, you know, be as comfortable as you can in your own environment for as long as you can. And then as you start to get into that active stage of labor, your contractions are closer together. It's more intense. You're really having to stop and focus to get through your contractions. Then that, you know, maybe that's the time that you want to come to the hospital so that we can kind of help you through that. And then transition is the most intense part of labor, but typically lasts the shortest amount of time. Now, I would say most first-time moms are going to come to the hospital. I think we talked about this last time. more out of like anxiety, like, well, I mean, what if I am 8 centimeters? Like, what if I do handle pain really well? Like, what if I just have a great pain tolerance? Like, we better go to town just in case, you know, and like you get here, like hoping that you're 8 centimeters and you're like 1. And it's like, well, shoot, like, you know, so then it, you know, then we might keep you, or we might send you home, or you might go get a motel for the night or something like that. And we are going to, okay, I hope everybody's ready for this. We're going to watch a live birth. It's recorded, somebody else's birth. But we're going to watch that. So if you think you're going to get queasy, please don't throw up on the carpet. But I think this is helpful. Have any of you guys seen a birth? Oh yeah, quite a few of you have. So if you've never seen a birth, and if you've never like been in a delivery room, sometimes I think it's really hard to like imagine like, what should I even do to be helpful, you know? So sometimes I think it's helpful to even watch the support person, like, oh, okay, I could do that, or that would be helpful, or you know, and it might just give you some different ideas. Like my husband didn't have a prayer when we came in to deliver, because I already had all these ideas of what I wanted and didn't want. You know, I was like, we're not having phones on, we're not having the TV on, like all these stipulations, just because I'd been in on a lot of deliveries and had, you know, seen what other people had done. So it might like give you like an opportunity to go home and discuss like, oh, I did like that, or I don't like that, or, you know, and that's like an ever evolving process that changes all the time.
Hi, I'm Brandy. I'm 37 weeks.
I'm Shane, Brandy's husband. Oh, I can't wait. And I can't wait for her to feel better again.
I'm ready to be done with this. You know, having a little baby. Having a Medicare birth is really important to me. Women have been having unmedicated births for thousands of years. The primal instincts to bear down, you know, to get in the squatting position, to breathe through it, you know, just allow the body to do what it needs to do. So I'm excited for that. Contractions started actually the weekend before that he was due, which was really exciting. So my labor support team included Shane, my mother, and then my doula, Molly. Early labor contractions, they definitely felt stronger than Braxton Hicks. Some at one point I could feel kind of start at the top and kind of push down. It's just the weirdest experience. This is really the uterus actually doing its thing. As we were timing them, it was like, oh, okay, they're pretty regular, because before they weren't regular. So we're like, okay, this is it. My doula, you know, she had come with a bunch of oils and stuff, so she was doing massaging, and that was nice.
During the early labor, to help Brandy with the contractions, I was just trying to, you know, suggest things that may help. Rub her back a lot, massage her legs, her feet, just trying to keep her comfortable.
You know, then we did do some yoga moves and, you know, kind of doing some stretching. And so that did help. Other times it was like, okay, I just feel like dancing, just kind of sway. So I lean up against Shane.
I made a call to the midwife just to kind of get some clarity.
I'm just calling to give an update on my wife's status with her labor. Yeah,
No. Okay, so yeah, I guess we'll just kind of keep counting and see how far apart they are. She basically said just, you know, kind of wait, but did, you know, tell me if I felt like I needed to go in, then just go ahead and go in at any time that I felt like it. So we waited. after the whole night of labor and stuff, we decided, okay, let's go in. We started walking around the hospital and it's like everything starts feeling funny. That's one of my
Contractions are, there were so many emotions. It was, fear, excitement. There's so much going on. It's hard to describe.
And I realized this is different, than from the early home labor stuff. So that's when after that, I was just like, I need to get back to the room and just be there. That was kind of like my comfort zone. Like, I don't want to be out walking around. I want to be in my room ready for whatever happens. So we're just opening the pelvis. Okay. Once I got into the tub, I was kind of like, okay, this is nice. I'm just kind of chilling, relaxing.
When I got in the tub with Brandy just so I could be there with her. She could lean on me. Sometimes those tubs aren't very comfortable, so just give her support.
I remember a few times Molly, kind of talking, doing a visualization. Each contraction was just a wave, and she's like, just ride with it, let the water flow over you. I'm like, okay, I can do this. I'm just sitting there and rocking with the waves, just rocking with the waves.
So from what I can tell, 5 to 5.5. Okay. Baby's head is really low. That's why you're feeling pushy, but we're not in the pushing place yet. So this is a good place to have you here.
When they told her she was at a 5.5, I was excited because I've always heard that from a 5 on really progresses and gets it pretty quick. So I knew that she was dilating more.
After a while, I was just like, I couldn't be in the tub anymore. Somebody had mentioned let's get into the bed. So I was leaning up against the back of it, kind of, rocking there, up and down, and kind of side to side. We had got the peanut involved. And then I was like, well, I don't like that. Let's see if I could drop down to the next level and kind of move around there. After a while, I was just so tired that I was like, I just need to lay down for a bit and rest. As each contraction came on, somebody had my leg and they were pulling it up toward me. And just kind of rocking it back and forth.
It was interesting that she came up with that on her own and just like, okay, do this. And, she took control and made sure everyone around her was doing what they needed to do.
So in between contractions, it was just like that relief. It was like, oh my goodness, big sigh of relief. It's just like, I can relax now.
I knew Brandy was getting close. I think she was about 7 centimeters, 7.5, somewhere there. I wasn't much help if I was completely exhausted, so I figured I'd just take a nap and build some energy.
It felt like a trash come on, and Molly was behind me, you know, that I still had to keep with that kind of squatting up and down movement. And then all of a sudden I felt her legs come in between mine to help support. So she was just literally holding on to me and helping me up and down because she could tell that I was starting to get tired and was just moving me through the movements. And then I felt like an icky feeling. And so when it got to that point, I was like, I have to get back in the tub just to kind of cool myself back down and just kind of get back into like a nice relaxed state. I'm not even sure if I knew I was in transition. It did feel different then, just because it's like I could tell just like the wear on my body. Felt like a death grip on like the faucet and the bar and stuff. And then I remember the midwife like, let's check you again. So I'm gonna check you. Let's see. I was like, a half? Why should be 10? What is up with this half stuff? Nobody ever mentioned anything about halves.
I just knew it was go time. I was ready for it. There, again, it was the whole rush of emotions, like when we first realized it was time.
And then the midwife checked one more time. She was like, all right, you ready? And I'm like, heck yeah. Yes.
Keep it going, Granny. One more.
You know, I rather wanted to do it in a squatting position, but I've been squatting and doing lunges and squats and everything else for hours and hours that once I was on that bed, I couldn't move.
Down your spine.
I was like, everything's opening. This is it. We're so close.
When I first saw Hunter's head start to come out, I could see his blonde hair. And it just, you know, I was like, oh my goodness, it's a real human being and he's going to be here soon. I couldn't wait to see him.
Right here, do you want to feel his head? And do you want to see it? See? Here's the here. More big push. Out the bottom, out the face. Yeah. Right there. You got it. Breathe in.
That whole like, I don't have to do anything now. I'm done. I'm done pushing. Like whatever energy I have to just be here. I remember Molly, she's like, you want to start breastfeeding him? I'm like, okay, how do I do that? You know? Oh, it was like so surreal. I was like, wow, it's like I have my baby in my arms and he's eating right now. So I mean, it was exciting.
Being such a big role in Hunter's birth was pretty amazing. It gave me a new view on life. Brandy's amazing. She is absolutely my hero. Just seeing her go through that and just be so calm, super proud of her. It's pretty amazing to have a newborn in the house that I can't keep my eyes off them. Just always want to hang out with them, check them out.
It's just wonderful waking up and like just looking at him and just like, oh, I created that and I birthed that.
What do you guys think?
Is he really 9 pounds?
Yeah, he looked like a pretty big baby. I was just visiting with one of our nurses, and her mom had 8 kids, I think, and had them all at home. And they were all like 9-pound babies. And I'm just like, oofta, that's too big. But some people just really are meant to birth 9-pound babies. One of the things that I was thinking about, remember last week we were talking about like how like all that motion and all that movement really helps to like jiggle baby down into that birth canal and to really get a good fit. And as you're watching her as she's laboring, like that was one, like every time I watch these videos, I think of something else, but like she just, even though sometimes she was laying in bed, she like never stopped moving. You know, she was like in the bathtub and swaying, and then she was slow dancing, and then she was on the ball, and then she was in bed
And rocking.
and somebody was moving her legs, and you know what I mean? So it's just like constant movement, constant motion, because that's what helps to jiggle that baby down into that pelvis. And like, so, you know, in the bathtub, but then out of the bathtub, like I need a break from the bath and I'm going to lay in the bed, and then the bed doesn't feel good. And then I'm doing this, and then I'm doing that, you know, and that's how it is. Like, I mean, you're like, the bed is good, and then the bed is terrible, and then the bath is good, and then the bath is terrible. And then you want to shower, and then you want to sit on the toilet, and, you know, it just keeps progressing. And so I feel like, of course it's tiring for the mom, you know, which goes back to like pack snacks, fuel yourself like it's a marathon, don't run out of energy. But it's also like, as I was watching the doula, you know, like as she's going up and down and she's like hanging on to her on her legs, you know, with every contraction, it's like, that's like tiring for the birth partner or the doula or the labor nurse or whoever's in there with you, you know. So just like if you're the labor partner, thinking about like, all right, like if we're going to do this for the next 36 hours, like, you know, pacing yourself also.
And also body mechanics. I mean, I like tear apart everybody's body mechanics everywhere I go. I can't turn it off. But if you guys saw when she was giving counter pressure, like the doula was like this. Like if you're giving counter pressure for 36 hours like this, your back partners is going to be killing you. So if you're giving counter pressure, get yourself into a better position too, which, I mean, this seems ridiculous, like that you're going to stand here, but everybody stand up. Let's give it a try. So, birthing moms, soon to be birthing moms, go ahead. We're going to get like how Brandy was, and go ahead and go onto the table with us. All right. And then partners, what you're going to do is so big hands, and find her hips. So you know where her rib cage is. So put your hand up on her rib cage, and you're going to come down until you feel those top bones of her hips. Yeah, so seriously, start up high, because hips are kind of a broad area. So start up high and come down and feel the top bones. And you're going to turn so your fingertips are facing in. Okay, and I'm going to time us. We're going to go for, what's the average contraction, Megan? A minute?
Yeah, let's do a minute.
Okay, ready? So you're going to press as hard as you can. On your mark, get set, go. As hard as you can. Oh, your hips are kind of loose.
Thanks,
Oh,
3 kids.
I'll let you feel it too. Okay, so here's ribs, right? So you're gonna have them walk down and then be here.
And I would say like pregnant ladies love this. And it's like, as we're talking about that baby's head coming on down here, not only is the baby's head not fused so that the skull bones can actually overlap, but also your pelvis is going to spread a little bit. And so it's like these bones and these muscles that have not spread like this before are spreading. And so I think sometimes that counter pressure is just super supportive and comforting.
Keep going, press hard.
And
Still have 12
this
seconds.
and this will be
5, 4, 3, 2, 1. Good. Now everybody rest for a second. All right. So you were a little hunched, right? You had your butt out. You had your butt out nice. I couldn't see your back from where I was standing. So go ahead and reset again. So ladies, reset one more time. And partners behind. So same thing. We'll just do it for a couple of seconds. Counter pressure and stick your butt out. So you want an arch in your back, like you're trying to reach your butt backwards for something, and then lean in with your arms. And try that and see how that feels. So you don't have to be quite so squatted, so you can get your butt a little more up. Yes. That's more comfortable. That's more perfect. Awesome. How does that feel for you? it makes a difference. Like your bodies have to get through this too, right? Like you've got to be that support for that long. So make sure that you're taking care of your own body mechanics.
And it's interesting, like, you know, like you might start off in labor and it's like, oh, that counter pressure feels, you know, in early labor, probably not so much. Everybody's still up taking walks and having a good time. But it's like once you get into like active labor, transition labor, it's like every single contraction you want that counter pressure because it just feels so supportive. And then it's like then you might hit a phase where it's like push harder and you're like growling at them to push harder. And then it's like all of a sudden the next contraction, like get your hands off me, you know, like that is the end of the counter pressure, you know. And so it comes and it goes, you know, like a lot of people like heat on their back. So sometimes like if a mom really likes counter pressure and she's having a lot of back pain or back labor, I'll have somebody go get like warm blankets out of the warm room. We'll put warm blankets on your low back with the counter pressure. And that might feel really great. And then pretty soon you like turn around and snarl at me and like throw the warm blanket across the room. Like no more warm blankets, you know, and then it might be like, I want a cold shower, but then turn the shower hot right now. And so it's just like always coming, like, what are we going to do next? Like, what's the next idea? You know, and just kind of having, and your labor nurse can help you with that. But if you kind of have some ideas like, gosh, I want to try the ball. I want to try the bed. I want to try this. I want to try that. At least you have some ideas that you can reference.
And we're kind of getting a little ahead of ourselves, but I've actually conveniently, for your use, put together a handout that when you're like, what should I try next? Here's some ideas. Some of these I think I probably gave you last week, so they're all kind of pinned together. But especially, so these positions are good to practice ahead of time. And I usually tell the dads that I work with, I say, when this isn't working and you need to change this, these are the things, right? So you start at one, okay, that doesn't work anymore. You go to the next one, okay, that doesn't work anymore. You go to the next one, okay, that doesn't work anymore. You go to the next one, no, I don't like that at all. You go to the next one, and then you keep circling back around as things stick, right? It is slightly difficult to tell what partner is what in these pictures. So if you have any questions, happy to clarify.
Oh, gosh. So we're going to talk a little bit about some different like true labor, false labor scenarios. Like, so what do we do if we're in this scenario? So it's 2:00 in the morning and you wake up to discover you've passed bloody show. What do you do? Does anybody know what bloody show is? Yeah. Yeah. Right. Yeah. So last time we talked about, right, you have the uterus and then you have the cervix, like the neck of the uterus basically. And as that starts to dilate, that plug that was keeping the baby in this really sterile, protected environment comes out. And so that can be your mucus plug. Now you do not need to like put that in a Ziploc bag and bring it to me. That's fine. You can pass on that.
How many of those have you got?
Well, not too many, but some people have like, you know, wrapped it up in a Kleenex and brought it in, and it's like, I don't need it.
We'll take your word for it.
Yeah, some people will like take a picture of it, bring the picture into us. Like the doctor doesn't want to see the picture. So pass on that. Well, what do you do if you pass your bloody show? Do we do anything? Yeah, no. So for some people, like you pass your mucus plug and then labor might start in, you know, an hour, might start in 24 hours, but it's also likely that it's not going to start for like 3 weeks. So it's pretty, you know, it's not very predictive indicator that labor is about ready to start. And some people really won't even ever notice that they passed a mucus plug. It might happen like amidst labor and they never hardly know. So it's 2:00 in the morning and you wake up to discover your bed is soaking, your water has broke. What do you do then? Clean up and then come in. Gosh, what a nice answer. Yeah.
They start bagging your bags.
Yeah, I was hoping that my husband was going to change the sheets and get everything ready. But yeah, you're right. Yeah, you can take a shower. You have a little time, but Like, this isn't one of those things like, oh, we still have 2 weeks, we won't worry about it. Like, the clock has kind of started, and we'd like to have that baby in 24 hours or so. It's 3 o'clock in the afternoon, and you've started to have some painless contractions every 20 to 30 minutes. You've been planning to go to the neighborhood movie. I don't know what movie that would be. It was supposed to be your last big night out before the baby comes. What will you do?
What's a painless contraction?
That's a good question. So a lot of times people will call them Braxton Hicks. Really, it's any contraction that's not causing cervical change. So sometimes you will just feel your belly tighten, and you might be just like buzzing around the house. A lot of times I'll ask somebody like, are you contracting? And they'll say no. And I'll put them on the monitor, and sure enough, like, they're contracting, but they're painless. They don't feel it. And so then it just kind of feels like your abs contract, and then you release them, and they contract. It's not painful at all. You just feel like, oh, my belly's tight, and now it's not tight anymore. So those are those painless contractions.
Has anybody been getting Braxton Hicks?
I guess I have.
Yeah.
Yeah.
And most of the time you don't even know it until somebody points out, like, that was just a contraction. Oh, that was just a contraction. So that's very normal. So would you skip out on your last night out on the town for those?
Good.
Yeah. So, I mean, they could go on for a long time before you
Weeks.
have a baby.
Weeks and weeks.
I did not pick the names of these moms, by the way. Marcella, a first-time mother to be a primate at 38 weeks gestation, went to the doctor for a regular checkup. She had lost 2 pounds in the last week and lost her mucus plug. Her exam revealed her cervix was 20% effaced, 1 centimeter dilated, and she's been having Braxton Hicks contractions for the past 3 months, but recent ones are starting to become painful. So what is meant by a primate? Does anybody know that term? So that's just a first-time mom. If you've had multiple babies, we call you a multip, but a primate is your first baby. Oh, yeah. Is it too early for labor to begin? She's 38 weeks. Nope. So remember last week we talked about like 37 weeks being our cutoff. Like if we go into labor before 37 weeks, we would want to come right in to stop it. But at 38 weeks, it's good to go. Is it dangerous to lose weight?
She just lost 2 pounds.
No. So it's pretty common. Like as your hormones start to shift right before delivery, it's not uncommon to lose a pound or 2 right before you deliver. So it's not uncommon. We talked about the mucus plug. Do you guys remember cervical exam? You guys remember what that means from last time? So she's 20% effaced and 1 centimeter dilated. Right? Right?
It's to like thick the cervix.
Yep. Yep. Right. So one centimeter, it's like the size of a Cheerio, and it's 20% effaced. So if it started off, 3 or more than that centimeters, it's still pretty darn thick. And if it's that thick and it's that closed still, it's probably likely still quite high. Yeah.
It's pretty interesting. Like I'll treat women at like 34, 35, 36 weeks of pregnancy. Like we're working on like perineal stretching and just prepping for labor. And a lot of women will be like, oh my God, the baby's head is like right there. And I am like searching for the baby's head. Like, so they're like, it is right there, but it's not right there.
And
it is
so
a
it's
lot of
always
pressure.
sometimes like, so like as people are kind of training to OB, sometimes they'll go in to check your cervix and they'll be like, oh my gosh, the baby's head is so low. And so you're like, oh, that's great. That must mean it's like just about ready to fall out if it's so low. But then like the doctor will come in and they'll be like, yeah, so you're still pretty high. And you'll be like, what are you talking about? Like somebody said I'm really low. Now you say I'm really high. Like, what does that mean? And so it's like when you go in to check somebody's cervix, like, I mean, maybe I go in this far and there's the baby's head. And like in the grand scheme of things, like correct, like this doesn't, like it does seem like that baby's head is really low. Like that doesn't seem like it's that far in. But when you're trying to push a baby under this bone right here, this is a long ways to push a baby. And so I really like it when that baby's head is like this far in.
And
or
we talk
this
about-
far in.
And we talk about the sit bones being at 0 station, and baby has to be 5 centimeters below that for like the big crown, right?
Mhm.
So like baby is that far down, right? So if you're like +5, you're still there, and that's
Yeah.
like what Megan's talking about. Like you're maybe only to your second knuckle. So if your whole finger is in there, that baby's way high up.
Yeah. Even though it's like to somebody that maybe hasn't done that many cervical exams, it's like you check and it's like, oh, baby's head is like that far in, but that's still quite a ways, you know? And so especially Dr. Gallagher, when he's delivering, he'll say like, baby's this far in, and then, you know, you push for another hour and then you're like, am I making any progress? And he's like, well, baby's this far in now. And you're like, are you for real? But like, this is how far that baby has to come, you know, when we're delivering. And so, you know, an inch of progress is a lot when we're talking about delivering babies.
Is she in
Is she in labor? Yeah, maybe early. Yeah. So she is starting to have a little cervical change, right? But it's probably that latent phase labor. And so yes, she could kick into full-blown active labor tonight and be delivering a baby, but she could also be stalled out at 1 centimeter for the next 2 weeks. So that's why we don't put too much weight on that cervical exam over in the clinic. So 1 week before her due date, Isadora goes to bed late after cleaning out the refrigerator and doing all the ironing. She sleeps for a while, then she gets up to go to the bathroom. When she stands up, she decides she's waited too long and she feels a trickle down her leg. She returns to bed after emptying her bladder and sleeps fitfully, waking periodically with cramps. At 6 a.m., she rolls over and is still, again, trying to get comfortable when she realizes the bed is really quite wet. What's going on? Yeah. So sometimes like your water breaking is like a gush of fluid, right? Like all over the kitchen floor. But other times it can be a slower leak, right? So it can just, but the thing is, and it's also like women also will just have urinary incontinence and just pee their pants. But amniotic fluid is not going to smell like urine. So I guess if you had to, you could get down on the floor and smell it. But if you pee your pants, like that's going to be like an isolated incident, right? But if your water breaks, it's going to continue leaking. So sometimes it's just good. Like if you're like, oh, I don't know if I just peed my pants or if my water broke. If you just put on a pad, if your water broke, you're just going to keep leaking. And then you should come in. What should she do? What might she be feeling soon? Yeah, so she might start contracting. And there's always that rare woman or it's not super rare, that doesn't start contracting when your water breaks, but hopefully she will.
And it sounds like she has the cramps that
Yeah,
could definitely be indicative of making change.
maybe they're going to get more painful.
Yeah.
By 2 p.m, she's at her birth location. Her cervix is 5 centimeters. Contractions are coming every 4 minutes and lasting 60 seconds. Is that a reasonable time frame? Yeah. How long until the baby's born? Yeah, probably a while.
She's got a ways.
Yeah. And what might she be doing? She's 5 centimeters, so she's probably just getting into that active stage labor. I'm guessing the fun and games are just about over. Things are probably starting to get kind of real. Yeah.
So, like, if you decide to get another girl, like, is that the point you end up doing it, or like?
So it is so different for everybody. If maybe we will watch another video here in a little bit, but like some people will come in and I'll just look at them and I'll be like, they must be 9 centimeters dilated. Like just watching the way they're moving and watching their body and stuff. And then you'll check their cervix and they're 1 centimeter. And I just think to myself, honey, you should get an epidural right now because like you look like you're in transition labor and your cervix is 1 centimeter, like we're never going to make it through this. But then there's other people that walk in the door and you're like, oh, they cannot really seriously be in labor. And then you take them back there and they're 9 centimeters and they're going to have a baby soon. So it's just every person is so different and every labor is different. And so I think you just have to like roll with the punches, you know? And if you're like, I'm 5 centimeters, but like, I'm still holding up pretty good in the bathtub and I'm still moving around pretty well and this is okay, like, then you might wait a little longer, or you might have been like, I am throwing in the towel at 3 centimeters because this is terrible.
And I think sometimes epidurals get a stigma too. Like we talk about it, like throwing in the towel, like give me the epidural, I can't do it anymore. But really like epidurals are a tool that you can use to get you through labor. So if you are at 5 centimeters and you've been laboring for 3 days, like there's this gal that I follow on social media, and she went from like laboring hard from 1 to 4 centimeters for 48 hours and went in and got checked, and she was just miserable. And so fine. And she really, really wanted, you know, she didn't want to like give up and get an epidural, but they're a tool, because if your body is fighting those contractions, if your body is like really struggling to get going, if you are exhausted and need sleep, an epidural is going to give you that relief.
And it's really a tool to have a vaginal delivery, right? Because the alternative is if you're completely exhausted, if you have no energy to push, if your body won't dilate, the only other way to get that baby out is a C-section. And so sometimes the epidural is a tool to help you relax enough that you can dilate and rest so that you can push that baby out. So it's, we do like, and I'm bad about saying that, like you're throwing in the towel and getting an epidural, but it absolutely is a tool to have a vaginal delivery.
Because it saves you from cesarean delivery, which then commits you in this hospital to a cesarean delivery from now on, right? So then you don't get to labor anymore. So it's definitely something to consider. But on the other hand, if, and this is something to definitely have a really good conversation around, if it's starting to intensify and you're fearful, like that fear, pain, tension cycle that we were talking about, if you find yourself spiraling into that, but you know in your heart of hearts that you can really handle it, well, maybe now we need to like look at positioning and like, should we try something different? Should we get in the tub? You start using, because if you do get an epidural, now you have 5 centimeters to go and you're stuck in the bed. And of course we can work around that. There are things that we can do, but it's so much harder when you can't move your legs. So I think there's two sides to the coin. So you use the epidural when you need it. But if you're really wanting to labor this baby and use that movement of the pelvis to move them down as quickly as possible, an epidural will take away from that. So
we're gonna play a little game. Okay.
To answer your question though, Jordan, I think the answer is that you can get an epidural at, like we were talking last time, at almost any point, knowing that by the time you ask and you get relief might be 40 minutes. But like she was saying, like our nurse anesthetists have put in epidurals like at 9 centimeters just with like a little hitter of the pain relief and just to get through pushing. So there's no true end, no true end. But I don't think I think there's a too early, but I think again, it's based on how you're presenting. Like if you're 1 centimeter.
If you're really, really early in labor, we don't want to put, a lot of times the doctors will say like, we'd really like you to get to 3 or 4 centimeters before we put in that epidural, just because we don't want you to be in that latent phase labor and we put in an epidural. Like an epidural is not going to last for 2 weeks until you have this baby, right? So we want you to basically prove that you're in labor and actually going to have this baby before we put in the epidural, if that makes sense. So this is just like a little birth plan game that we play. So what we want you to do is lay out on the table like what your ideal birth plan is. Like if you could choose, what do you want? And if you guys need coffee or water or anything, just help yourself.
Okay, so my goal is
Were you the one telling me about the, Megan, were you the one telling me about the C-section C-section thing that Dr. Tan uses? What's that? The C-section thing that Dr. Tan uses, where she like puts it in there and it like does something.
Yeah,
opens up and there's something over there.
Yeah, so I guess Dr. Tan uses it and then the other guys do.
That's weird.
And
we'll just kind of go around the room and you guys just read off what you have in mind. And of course, this will elicit a lot of questions like, what is this episiotomy business, you know, as we go around. So just name off like what you want. So we'll start with you guys. What do you want?
I'd like to walk as long as I can and then do an epidural.
Okay.
I didn't know if you meant like extra pain meds or just the epidural, so I said no extra pain.
Okay.
Vaginal delivery, no episiotomy, hopefully. Short-term labor, no forceps, and it's a boy.
Okay. What about you guys?
I put short labor, walking during labor, at least inpatient. I've never seen an inpatient labor in mom without an IV.
Yeah.
Vaginal delivery, and I'm open to an epidural. I really don't want an episiotomy, but I know its purpose. I really don't want to use a vacuum, but again, I understand it.
Okay.
I find short labor, I take an IV if I need an IV, I don't really care either way. Rather not have forceps or vacuum. Would like to walk as long as possible. Don't really care about an epidural, like if I need the epidural, I'm gonna take an epidural, but I would rather not if I don't have
Not
to.
committed.
Yeah, no. I hope no enthusiasm there. Vaginal delivery, don't really care about pain medication. And I want a baby. I like vaginal delivery, short labor, walking during labor. Ideally, I'd like to have no epidural, no pain medications, no episiotomy. I would like the IV and no vacuum. Baby boy.
So let's talk through like a few of these things because this always brings up questions. So the card that says intravenous and it has like a picture of IV fluid. So what I like to say about this is that when you come in to have a baby, everybody's going to get an IV put in, right? So you're at least going to have an IV placed, but you won't necessarily have like a pole with fluid dragging around behind you, right?
Like what Brandy had in her wrist, like it's a little port.
Yeah,
looking thing.
just a little IV site. It's taped down, and it's just there so that if we need to give you fluids, if we need to give you medications, if we need to do something for a baby, it's there. Like I had one patient that was, you know, I was like, if you hemorrhage, I need an IV, and she was like, well, why don't you just start the IV if I hemorrhage? And I'm like, well, because it's an emergency at that point, and I don't have time to start your IV. So we just want that IV site in place. But for the most part, we don't have you on IV fluids. You're still up, walking around, drinking.
not dragging a pole all around behind you, okay? Let's see.
Can we talk about episiotomies?
Yeah, sure.
All right, does everybody know what an episiotomy is for starters? Okay, so if you're unaware what an episiotomy is, it is when the doc so usually this is like at the end stage, like when you're pushing baby out, baby's really close, they'll see that maybe baby's getting stuck on your perineum. So that's this. So here's like clitoris, urethra, vagina, rectum. So your perineum is this, we call it the perineal membrane. It's actually where your muscles tie into of your pelvic floor. And so a doc will take scissors and snip. And a lot of times this helps, and like, you know, like we were saying, like this is the difference between baby coming out and you birthing baby versus like having to go in for a C-section and pull baby all the way back out. So, so it's much easier to just clip through this tissue. It is not a surgical procedure. So it's not like okay, we're gonna be 5 centimeters from this landmark and 5 centimeters from this mark and then make this teeny little cut. They're like, and just come down with scissors. Right, so it is not, you know, like I'm pelvic floor PT, so the thought of an episiotomy horrifies me initially. However, I will say that of all of my patients that I've had, those who have episiotomies don't even notice it. Your perineal membrane actually has like very few sensory receptors because it's mostly connective tissue. So it's not that you won't feel it, it's just that of tearing that's happened, the perineal membrane cuts versus tears tend to be less painful. So I think that that's something to add. So if they start coming at you with scissors, like in that last stage of delivery, like don't be like, no, like it'll be okay. Like your perineum is going to be fine. There's some argument like allowing someone to tear on their own along the lines of the weakness of their muscle versus cutting. I mean, there's some discussion there. But again, like folks who have torn on their own or folks who get an episiotomy and then tear more, those are the folks that tend to be more painful. Or like I've had folks who've like torn up this way, like up through their labias. And episiotomies are graded based on how deep they go. So you can have occasionally you'll have someone who will tear all the way through the rectum, or will have like Megan's about to show us, like you start an episiotomy and then it'll tear all the way through the rectum. Do you want to show that before?
Yeah, so it used to be routine, right? That we did epidurals on everybody. So everybody got an epidural, or episiotomy, sorry. And so I was having this discussion with Dr. Gallagher because I was like, it's way easier and less painful to heal from an episiotomy than it is just a spontaneous tear. So like, I'm not advocating that we do an episiotomy on everybody, but like, why did we change? Like, what was the change in practice? And so this is what he demonstrated to me. He's like, if you just have like intact tissue and you're pulling on it, like not much happens, right? Unless there's a lot of force against it. But if you cut the episiotomy and then you put that same tension on it, there's a weak spot and it tears a lot easier. And so when they were just cutting routine episiotomies on everybody, then as that baby's head came out, there was a weak spot and it tore a whole bunch more. So by not cutting episiotomies, yeah, we do have women that do tear spontaneously, but the tear is generally not like this, right? It's a lot less, like a 1st or 2nd degree tear versus a tear that's going clear through your rectum.
So don't be too scared for your vaginas and perineum, because there's some things that you can do to prepare. So perineal massage is one thing. We pelvic floor PTs used to recommend that like during labor, like the nurse or the partner get in there and really start stretching the tissue. And then like for anyone who's like ever done a really hard workout or you like overstretch your shoulder, like then it hurts like immediately after, right? So now we think about it more like you have tight hamstrings and you're looking to like stretch them over the next little bit. So my recommendation, and I've got a handout for how to do it, but I recommend at about 35, 36 weeks, you start doing perineal stretching at home, like 2 to 3 times a week at least. And so what you do is, it's a partner activity, unless you have really good flexibility. So what you do is you take 2 fingers. If you think about the vagina like a clock, so clitoris is at 12, rectum is at 6. You're gonna be at like 4 and 8 and you're going to pull. And you're going to pull until it burns. So partners, if the people in here are going to be the ones doing the pulling, you don't like start here and then go poop. Like you want to go like nice and slow until she tells you to stop. And where you want to stop is when it's like a good burn. Like, ooh, that's a solid burn. I need you to stop, and you hold. When that burn goes away, you stretch a little farther until it burns again, and then you hold. Right? We'll never be able to really create like what that like 13 centimeter diameter head is coming through. But what you can do is you can improve the tolerance of your tissue to stretch. Just like if you had tight hamstrings and you'd like start a stretching program 2 to 3 times a week, you stretch until it's uncomfortable, and then over time you would gradually get more and more flexibility. Same thing here. Because part of what we find happens with women is you get to that last stage of pushing. So you're at a +5 station, right? And that large crown. And what do we do when we're in pain? Like, what's our response? What do we do in our bodies? Yeah, you pull away from it, you tighten. And so the pelvic floor does that as well. So if the pelvic floor is used to a deep stretch, used to like a pretty uncomfortable, painful stretch, then we find that folks do better and better. So this is definitely something that can help prepare you for a labor and prepare to like get through, like we said, with that intact tissue and not need that additional push forward or not need that additional cut to help baby come through. But if you do end up with an epidural, not the end of the world. You can always come see me and we'll get that scar tissue fixed. And it'll be fine. And did I say an epidural now too?
We're saying it like crazy. We're losing our minds.
And I would say too that we've had folks who have had multiple children, tore with all of them. We like do some really good work on the scar tissue and really work on improving like the elasticity of that tissue and improving the tissue's tolerance to stretch. And then on the next baby, no tears at all. So, so I think I would totally recommend doing this. Very, very important to start. Probably, I mean, you can start as early as you want, but definitely start by 36 weeks.
So one of the next cards probably says forceps or vacuum. So forceps are kind of like, they're a little bit.
They look like salad tongs.
They do, like giant salad tongs. But most of the providers like aren't trained in forceps. I mean, they did forceps back in residency, but what most of them are doing now is a vacuum. So this is a vacuum extractor. And so if the doctor, if that baby is like having like the time that we would use this is like, if that baby's having a really hard time getting under that pubic bone, and we're just having a hard time getting out through that perineum, the doctor will take that vacuum and put it right on the back of baby's head there. And then they pump it up like this to increase the suction. And then they're going to use that to gently put traction on that baby's head to help pull that baby's head under that pubic bone, right? That's going to help get that baby underneath. So these are typically not on for a super long time. We only like to have them on for like 20 minutes or less. And when the vacuum is like sealed to the baby's head, if the vacuum does what we call pop off, where it comes unsealed from the baby's head, we can only let it do that 3 times before we have to abandon the vacuum, right? Because there's very strict guidelines for vacuum use to make it the safest for mom and baby. So that's one time that the doctor might cut an episiotomy, is if we're trying to get that baby's head underneath, but the tissue of your perineum is tight enough that it's going to cause that vacuum to pop off because there's not quite enough room. That's going to be a time that the doctor is going to talk to you about cutting an episiotomy to make more room for that baby's head to come under with that vacuum. So typically the doctors will talk to you about a vacuum prior to putting it on. They might show it to you even before you start pushing, just to say, hey, this is a vacuum and I might use it. Dr. Gallagher usually says this is not something that like 10 minutes into pushing, you can be like, okay, like I'm tired. Can you just go ahead and get that vacuum out and help me out? Like that's a hard no. So this is like, if you've been pushing for more than 2 hours and you're just gassed and you don't have any energy left, or if baby's heart rate is really starting to decelerate and we're a little concerned about baby, that's going to be a time that we're going to talk to you about putting the vacuum on and using that to get that baby out. So the biggest risk with it is an intracranial bleed. And the risk of that with just a vaginal delivery is like 1 in 1,200 babies. And the risk of it with a vacuum is like 1 in 800. So it does increase the risk a little bit, but then again, it's a tool to a vaginal delivery, which is less risky than a cesarean. So I was a vacuum baby, and my first 2 babies were vacuum babies. And I would say on first-time moms, we use it probably about 25% of the time. So it's not uncommon that a first-time mom is going to see a vacuum for delivery. And it's, you know, once again, it's a tool to facilitate a vaginal delivery.
One thing to think about too, in terms of getting baby underneath the pubic bone, we talked last week about how the distance between your pubic bone and the tip of your tailbone is the narrowest part that baby has to get through. So if you think about a typical, let me flip the camera around there to me. If you think about like a typical birthing position, right? And we saw Brandy, but it's like this, right? Like this is how a lot of women give birth. The problem with that is that you have the tailbone, like you're pressing your tailbone against the bed, right? And so your tailbone's pressed there and it has nowhere to extend to. So we don't really think about the tailbone having a whole lot of movement, but it's got, you know, probably a good centimeters worth of movement, which when we're talking millimeters in the rest of the pelvis is pretty impressive. So if you do have an epidural or you feel like this is the position in which you need to push, one thing, and not even if you have an epidural, but if you wind up in this position pushing, first of all, I would recommend, like if you have an epidural, being more on your side, being in a squatting position, like hands and knees. I would recommend a different position entirely. However, if this is the position your body needs to push in, or you just find yourself in, one thing that you can do is get one sit bone off of the ground or off of the table. So you roll one sit bone up and now your tailbone is free to move. So that's one thing to think about as well. And you ladies probably won't be thinking about that like babies that, you know, you're like baby's right there and you just can't get them past the pubic bone. But one thing to think about, especially partners, is shove a pillow underneath one side of their butt to get them up and get them off their tailbone. So then baby has a little bit more room to come through. And then the perineal massage is going to be helpful with that too, you know, because you have the soft tissue of the perineum that can be a block, and then you also have the coccyx, the tailbone, which can be a hard block as well. So if you can give both of those some freedom to move, that'll be significant.
Any other questions on these cards? So now, why don't you guys flip all your cards over?
How do you feel about this birth?
That's so true. And I think that's why we play this game is just like, because at the end of the day, what we want is a healthy mom and a healthy baby. And that really is the most important thing. And most likely it's not going to happen exactly how you envisioned it or exactly how you planned it. And maybe it will happen like in Annika's case, like absolutely everything that you never wanted is what you're going to get.
This scenario happened to me. I had it one way and then we flipped all the cards.
Yeah. So, but at the end of the day, we want a healthy mom and a healthy baby. And so I think just coming into deliver, like as open-minded as you can is really the best. I mean, I think it's great to be informed about the decisions so that if like, you know what you're agreeing to, or you know what could happen or couldn't happen, but just being as flexible as you can, because more than likely it's not going to turn out exactly like you envisioned.
One thing that I've learned in my experience birthing, right? So I had a pretty traumatic first birth that went completely opposite of everything I had planned. And even my second birth was not what I had planned. It ended up being the opposite of what I had planned. But I went into the second birth with more, rather than a specific, like, I want this and this and this, like I had more of a big overall picture of how I wanted to feel coming out of birth. So did I want to feel like, you know, like it, like for me, like it was really important to get skin to skin right away. So I knew that I needed to be calm going in, like, so that way my baby could be calm. Like she didn't have a bunch of stress hormones going into her, right? I wanted it very quiet and calm and peaceful. So we didn't allow family in for like the first 6 or 7 hours. So, you know, sometimes having a bigger, like when we say that coming in open-minded, sometimes it's having that bigger goal of what you want your birth to feel like rather than what you want your birth to look like, if that makes sense. So like, even though I wanted like a super hippy dippy, like everyone like waving and chanting in the corner vaginal birth the first time, and I had all of the medical interventions with all of these strangers and wound up in the NICU. And in the second birth, I wanted a VBAC, and I wanted, you know, I had given up on the waving people chanting in the corner, but I still wanted this like natural birth experience, wound up with a C-section. I came away from the second one feeling like it was the birth experience I wanted, even though my birth plan didn't go as planned. Does that make sense? So you have like a bigger overall picture, and like all I want is a baby at the end. Whatever happens, happens. What do you want that to feel like? And getting your head wrapped around that, I think, is a really good way to come through. That's kind of a very like not super well defined, but I think having. And it's hard to imagine if you haven't been through it, but trying to, I don't know, maybe talking with a lot of people, or just what do you think it's going to feel like to hold that baby in your arms, and then let that be the focus of how you know, set up your birth plan or set up your birth experience. Does that make sense?
Do you guys have any questions? So we're going to talk a little bit about pain management. So, you know, we'll talk about like more non-pharmacologic interventions, but right now, like, let's just talk about what, you know, Dr. Gallagher always says, better living through chemistry. So let's talk about that chemistry that, you know, is your option. So the first option would be IM medication, so in the muscle. So we don't do this super often, but let's say you came in and you were like contracting and you were uncomfortable, and we check your cervix and you're 1 centimeter dilated. And you know, so we're like, well, you're like in early stage labor, you know, we're not going to give you an epidural right now. We're going to send you home. And you just break down in tears because you're like, I can't go home. I can't sleep. How am I going to do this? So an option might be that we give you a shot of IM pain medication, and maybe we send you home for the night. And it's just enough to like kind of take the edge off and help you go to sleep, so that maybe you can get some sleep through the night. And as your labor, like, you know, slowly progresses, maybe you wake up in the morning and you are in more active labor, right? So it's a longer acting medication that we don't give super often, but if we are going to give it, it's going to be in early labor. So then the next option would be IV medications. And so that would be just like 1 or 2 doses, usually of fentanyl, that we would give you right into your IV. This we also don't do super common, because we don't want to give it too close to delivery, because it can have sedating effects on baby. So then baby comes out like not as eager to breathe and cry. So like I would say, so we have to check your cervix before we give it to you. So if you're like, I need some IV pain medication, okay, we'll check your cervix. Like if I'm your nurse, I'm probably not going to give it to you if you're past 7 or 8 centimeters dilated, because I don't want you to deliver 10 minutes later and have a baby that's not too eager to breathe. So, I mean, sometimes a dose of IV pain medication just is like enough. Most moms say that it doesn't take the pain away. It just like allows you to breathe. So sometimes if you're like, maybe if you're getting into that like fear, tension, pain cycle, and you're just having a hard time like getting it together, maybe a dose of IV pain medication would be enough to like help you like reset your focus and maybe get in the bathtub and calm yourself down and get into more of a positive cycle. But by no means is it going to take the pain away. And I'm not going to give it to you again, like when you're 9 centimeters, like you're not getting it then. So it's, you know, if I have a mom that's like, you know, 3 centimeters and she's like, I need some IV pain medication, like we're probably going to have a pretty serious discussion about an epidural, because if you're using IV pain medication at 3 centimeters, how are we going to manage your labor when you're 5 and 7 and 9 and 10 and pushing? Because I can't give you that much IV pain medication. And then the last option is an epidural. And that, of course, is the most common method for pain relief. So I haven't heard anything from Gabe. So if Gabe is going to come in, Gabe or Andrew are our 2 anesthesiologists. So if you decide that you want an epidural, we will call them and they'll come in. So one of the 2 of them is on call 24 hours a day. And so they'll come in. If you want the epidural, we have to make sure you have an IV in, and then we would bolus you a liter of fluid. So that takes, you know, 10 minutes to get a liter of fluid in, because an epidural can drop your blood pressure. So we kind of have to bolus you up ahead of time. So they're going to come in. They ask you a few questions, just like, do you have any medical history? You know, have any problems with anesthesia in the past? And then they're going to sit you up on the side of the bed. So last week, Annika was kind of doing the cat and cow poses on the floor. So that's what they're going to ask you to do. So you're sitting on the side of the bed and your significant other is probably right in front of you, like maybe hanging on to you. And we're probably monitoring you, and we probably have a blood pressure cuff on you. And so you're going to sit up, and they're probably going to have you tuck your chin to your chest and really curl around your baby and really push your spine out as much as you can. And that just opens up those vertebrae in your back so they have more access to that epidural space. So with my first baby and my third baby, I didn't have an epidural, but with my second one, I did. And I just remember, so the first thing they do is they clean your back with chlorhexidine. And I had been in labor for like 36 hours, but I just remember now the chlorhexidine is just like a cold, wet sponge, you know, running around on your back. But I remember that being like the most like irritating part of the whole procedure, just like that cold chlorhexidine running around on my back. And I think it was just like, you know, like my threshold for pain at that, you know, it was just like anything was going to tip me over the edge. But they clean your back, and then they put a sterile drape over your back, and then they just use lidocaine in a little syringe. And that's what most people consider the worst part of it. And so it's like a poke and a burn where they inject lidocaine right around the epidural site there. And then once you're numb to the superficial touch, then they're going to take the epidural needle and they'll have you hold really still, and they're really good about working through your contractions. So like if you're like, oh, I'm having a contraction right now, they'll wait until that contraction's over and then say, okay, like tell me when I can go. And then as soon as that contraction's over, then they'll start putting that epidural needle in, and they put it in really slowly until they're in the right space. And then as soon as they're in the right space, the needle is fairly big. And so then they can take just a little tiny clear tube, and they thread that clear tube into the needle and into your epidural space, and then they pull the needle out so that all you have left in that epidural space is this tiny little plastic tube, right? And it's long, it's like this long. And so it's in your back, probably this far, like that much of the tube is inside you. And then the rest of it, we just run up over the top of your back and tape it over your shoulder. So if they really like you, they'll even move your hair out of the way and not tape all your hair down with the epidural. And then they'll usually give you like a bolus dose, and you might feel like your legs get like warm and tingly. And then they'll set up the pump so it's continuously infusing. And then we'll lay you down in bed. And usually after that bolus dose, like it's pretty quick, like maybe only a couple minutes, and you'll start to feel pain relief.
At what point does the tube get taken out of your back?
After you deliver. So generally, like most moms get up to go to the bathroom like around 2 hours postpartum. And so like when you get up to go to the bathroom for the first time, you know, we'll just have you sit forward and just pull it out, put a Band-Aid on your back, and that's the end of that. So that's pretty, I mean, it's pretty straightforward. There's always a risk of infection and bleeding. That's like pretty minimal risk. And then The other risk is what we call a spinal headache. And that can be like pretty miserable if you're the patient that gets it. And it's just like a really intense headache if you're sitting up or standing up. But if you're laying down, there's like no headache at all. And that usually lasts for a couple days and then it goes away, and they can try to treat it. But I don't remember the percentage, but it's like 1% or something. Like it's a pretty low percentage that gets a spinal headache.
You also might notice some bruising on your back too. Like I remember, so I didn't get an epidural, I got a spinal, which means that they go like one step further into your spine for the C-section. And I remember like leaning back against something and being like, ow, what's on my back? And then leaning back, ow, what is on? And then remembered that, oh, right, there was lots of needles back there for a while.
Mm-hmm.
So I can miss that as well.
Questions on the epidural? So once you place the epidural, then we're also going to place a catheter in your bladder to drain your bladder. Just because once you have the epidural, you won't be able to feel the sensation that your bladder is full or that you need to pee. And the baby's head and your bladder are competing for the same space. So we need that bladder empty so that baby's head can drop down. Questions?
So it's usually like
All 3, all 4 probably.
You've had what?
Back surgery.
Uh-huh.
So was that effective?
Most of the time they would say no. Like we even had a gal that had like scoliosis and like spinal fusions, and they were even like, no, I think it'll be fine.
And part of that has to do with where they're going in. Like even if you have a fusion, they're usually like fusing the pedicles, which is right here. And so you still have the foramen where the nerve comes out. So it's in a different spot.
And these guys are super good. Like I really do trust them.
Yeah.
They're really good. And they're good. I mean, they're so good about working with you. And just, the other day I had a gal that was, she was complete. So a lot of times then once you're complete, once you get to 10 centimeters, we're going to turn the epidural off, which is like, no mom wants to hear that. But we want you to have some sensation when it's time to push, because if you've never pushed a baby out before and you feel no pain, like, why would you be bearing down, pushing a baby? What triggers you to do that? Like nothing. And so if we turn the epidural off and you start to regain some sensation and you can at least feel the contraction and you can feel some pressure, you're a lot more effective in your pushing. If you can kind of feel where you're pushing. And so it's not uncommon that we'll turn off that epidural when it gets close to the time to push. But I had a mom the other day that was like 10 centimeters for like 6 hours, and we just kept redosing her epidural because baby was still really high, and we knew she was going to have to push for a long time if we started pushing too early. So instead, we like bolused her epidural so she got more pain relief. She took a nap, and we let her body just keep working that baby down lower, just letting everything stretch out. Good. So we've talked about a lot of these. So medical interventions that you might encounter while you're here. So an induction. So at some hospitals, they'll do an induction once you're 39 weeks. You can like call and schedule your induction, but we don't do that. So generally the docs are waiting until you're closer to like 41 weeks. Like we're doing inductions at 41 weeks. Dr. Graham, you guys are Dr. Graham? No. Is anybody Dr. Graham? Nobody. Okay. Sometimes Dr. Graham will do 40 weeks, but I would say the rest of the guys pretty much stick to 41 weeks. So like Annika was saying the last time, like only 25% of people have delivered on their due date, right? And then if you go to 41 weeks, what?
It's only 75%.
And then by 42 weeks, 90% have delivered. But like there starts to be like a cost benefit ratio, because at 42 weeks, the rate of stillborns also goes up. And so it's like the placenta has an expiration date. It's not going to last for forever. But at the same time, doing a lot of inductions increases your C-section rate. And so we want to give you ample opportunity to go into labor on your own. And then if you don't, we would induce you. So most of the docs are starting their inductions with Cytotec, which is just a tablet. It's a prostaglandin that we put in right next to your vagina when we do a cervical check.
or we put it in right next to your cervix when we're doing a cervical check. The other thing that Dr. Tan does is a Foley catheter,
Balloon.
yeah, balloon induction. So she'll take, I don't know if I have one. So she'll take a catheter like this, and they have a little balloon at the end of them, and she can inflate it right in your cervix, and just the pressure of this plastic balloon will help to pull your cervix open. And then once your cervix is 3 centimeters dilated, this will just fall out because there's nothing hanging onto it anymore. And then from there, they can move on to a different method of induction. So an induction is just like going into spontaneous labor. As far as once you make it, you know, past 4 or 5 centimeters, then your body really will kick into active labor and go faster. But sometimes getting there can take some time. So if you're coming in for an induction at 41 weeks, I would pack your bags, planning to be here, you know, for a 2-day induction, and then have a baby and then stay for another day and go home. Right? So like you might be playing cards, and you might be watching movies, and you might be reading books, and you might be taking walks, and then you'll finally get into active labor and use all these things that we've been telling you, and then have a baby and go home. IV fluids, we talked about that. Fetal heart monitoring. So we will have you on the monitor on and off throughout your labor. If you or baby aren't tolerating labor, we'll have you on the monitor more frequently. If everybody's doing good, then we might just be checking you, you know, for a few minutes, like every hour. But we can certainly, I mean, the easiest thing for the nurse is to just slap you on the monitor and walk out the door. But we all know that's not the best thing for the patient. So if you're like, my gosh, I've been on this monitor for a long time, like, don't be afraid to speak up and say, like, can I like get off the monitor? Can I walk around? Because we do have a mobile unit where you can be on the monitor, but still walking around. And I just submitted today monitors that can go in the bathtub, a purchase order for those. So I think it'll be nice to, you know, like, but advocate for yourself, like, you know, ask, like, can I get off the monitor? Can I, you know,
Yeah, don't
can
be
we
afraid
do
to-
like, because for sure it's the easiest thing to do to slap a patient on the monitor and just walk out the door. But that is not the best thing for the patient. So don't be afraid to speak up, advocate for yourself. An intrauterine pressure catheter. So just one of the monitors that we put on your belly monitors the pressure of your uterus, and occasionally it's difficult to pick that up. So we might talk to you about putting in what's called an IUPC, and that's just an intrauterine pressure monitor. And so it's just like this skinny little clear tube that goes right into your uterus, and it just measures the pressure of your contractions, and it just gives us a more accurate reading of how effective your labor is. Fetal scalp electrode. So normally we just have you hooked up to the monitors and the belts around your belly. But occasionally, if we can't pick up baby's heart rate like through the wall of your abdomen, this again is another tool to have a vaginal delivery. So it looks kind of terrible, but it has this little pinprick on the end of it. So what we would do is we would go inside your vagina and then thread this through the cervix onto baby's scalp, and then rotate it like a twist and a half. And this little pinprick just goes right into the skin on the top of baby's head. And then it connects to our monitor outside of mom. And that allows us to really accurately monitor baby's heart rate. And again, that's just another tool that, like, if we can't determine baby's heart rate monitoring from the outside, you're most likely going to end up in C-section because we don't know how baby is tolerating labor. But if we can get a more accurate reading of how baby is tolerating labor, that might allow you to go on and have a vaginal delivery. So I'll pass it around and you guys can look at it.
So comfort measures, you know, we've already talked through some of these. I really like the video that we show with Brandy, because I think they do a really nice job of like promoting relaxation and massage and visualization We talked a little bit last week about the different techniques that you can use. So of course, there's all the different types. Like there's the hypnobirthing and mindful birthing and Lamaze. So there's all these mindsets that people can give you. But definitely something to think about as well is like bringing in tools for that. So like, what's relaxing for you? Is it a massage? Is it warmth? Is it like having like we said, creating your nest, so your own blankets or maybe a diffuser, whatever you need to have that relaxation. And I think, I talked a little bit about in my birth experience, not wanting to have a whole lot of stress going in, even though like the whole situation was kind of stressful. I would say also, like labor itself is kind of stressful. Like it will be one of the most dangerous things that as a woman you will probably ever do in your life, and you'll do it consistently, right? And we do it happily. And so having things that keep you relaxed and promoting, especially in early labor, those feel-good hormones that are trying to course through your body and help with that relaxation, that dilation and effacement and descent of baby through. You want a lot of relaxation for that. Massage is really fantastic. If you guys look at the back side of the positioning paper, these are some pain management and comfort measures that are pretty consistently good. So we have sacral counter pressure. That's very similar to like pushing in on the hips, but instead you have a hand on top. So you have a hand like right at the base of the spine, and then another hand on the side of our hips, and then you're just going to be pushing into the sacrum, right? So rather than squeezing this way, you're pushing down this way. Does that make sense? And then we've also got counter pressure. So you can do the double hip squeeze, and so you can either squeeze that high like where we were just squeezing, or you can squeeze it low. And there's some different strategies for that we'll talk about when we talk about positioning. The double knee press. So if mom is like sitting in a seat against the wall or sitting in the bed, like with it upright, you can just grab like both kneecaps and push directly backwards. That again is going to be like, it's going to be some forward counter pressure against the pelvis as well. I really like some of these other positions. So belly lifting. These are, we won't run through them tonight, but I encourage you like at the end of class tonight to give these a try. So essentially what you do is you can take a blanket and wrap it around mom's belly and just lift and kind of relieve some of that pelvic pressure. We talked a little bit about that shimmying last week, where you can just grab hips and start to shimmy. I also kind of like the one, if you look at the sifting and rocking, mom would be laying on her back, and then you'd actually like lift her butt up and shift and sift that way. And then you can also do it so you can be on the belly, you can be or under the belly, you can be on the top of the pelvis, or you can be like lifting hips up and shaking that way. And a lot of that, again, like we're just looking to get muscles to relax. Muscles tend to respond well to vibration. Like if you've ever seen massage, or like sometimes in the movies, they'll show you like massage therapists who are doing what's called sapotement. And so this is kind of doing the same thing, like just shaking the muscles or shimmying the muscles just a little bit to get them to release. This head wrap is really kind of interesting. What you do is you wrap it around mom's head and cover her eyes. And then you give it a twist, and then you can take it and tighten like this. There's something about like shutting out the world and putting some pressure here that, and I think a lot of it actually has to do with like gritting your jaw, which is going to grit your pelvic floor. It's going to make your pelvic floor tighten as well. So it's like counter pressure against the muscles of your skull that are like also contributing to tightening your jaw. So that's a nice counter pressure measure as well.
That just works by like if you make the mom pass out.
Right. Also, if you cut off circulation, right? Yeah. So watch out for the nose. Definitely go for the eyes. Visualization and focal points. Again, like this is something. One thing that Brandy did that I really liked is she had a lot of rhythm. If you saw, like she wasn't like inconsistently moving. Like everything kind of had a pattern. And there was one point where she was like rocking on the bed, and every single person around the bed had like joined her rhythm. Like they were moving side to side.
Labor is the most rhythmic thing.
Yeah.
Like, oh my gosh, like you do, like you just. And you won't think about it. Your body will just naturally do it. And you'll just be like moving and shaking and yeah. Mm-hmm.
One other thing that they said too, that I think is really important is, so vocalization. So I think a lot of women are scared to vocalize during labor, and I would really, really encourage you to not be scared. So don't be scared to vocalize. But one thing that they did in that video that I think is really important to hit is, she said, out through the bottom, not the top. So if you guys use your books, you can use the, there's like a key in there that you can go in and rewatch some of these videos. And she has like, the doula is coaching her to be like, push, and have like this low bray, basically. Like it's this low, like deep and low vocalization versus like this like screaming, like high floaty vocalization. And the reason for that is doing a low vocalization like that actually relaxes your pelvic floor. The other thing that she did that is really interesting is which is another technique to relax your pelvic floor. So like it's called a bilabial trill, which you will never need to know, but that like making the horse noise or doing like a low, like moaning is really, really good in labor, because what it does is allows energy to release. Like you're not valsalvaing, you're not like bearing down and causing reflexive tightening of your pelvic floor, but you are allowing some of that energy to escape, and therefore like we call it a bulge in the pelvic floor. So you're pressing against the pelvic floor without pushing. Does that make sense? Like it's a slow release. So low vocalization or that bilabial trill, like a bzz, like a bzz wouldn't be it, but like anything that's making your lips move like that is something that you're going to be looking for. And then laboring positions. So if we flip back to the front, all of these positions, they can be customized based on your own personal history. And this is something like when you're looking at the stroller checkoff, this is definitely something that we can go through. So one thing to consider is that in early labor, if you think about, we talked about like baby's actually pretty darn high. So if you think about baby's head being up here, we think about the pelvic inlet coming this way and the outlet coming this way. So in early labor, you want to make sure this is nice and open as possible. So when we were talking counter pressure, this might be where you want to do some low counter pressure. And when I say low, like it's counter pressure like at the like down here, you're going to feel like it's on the thighs, which it kind of is, but you're low counter pressure at the hips to open up the pelvic inlet. Does that make sense? So these first positions, this first set of positions at the top of the paper, these are all designed to help open the pelvic inlet. So forward flexion of the low back. So that's like a rounded low back. That's going to help open the pelvic inlet. Knees together and heels together. So a more, come on, let me come over here. Take my mask off. So we're thinking knees together and heels together. So this type of position. So if you're going to slow dance, maybe think slow dancing with your knee, like slow dancing like steps closer together. If you are, and then with your back rounded. So like a 6th grade dance, right? So dancing more like this. Versus in later labor, if you're going to be slow dancing, it might look more like this. Do you see that difference? So early labor, late labor. And the difference is now you have that pelvic outlet. So the lower part of your pelvis where baby is coming from, now you want, it's like a funnel. So now you want your pelvis to do this. So like if you go heels out, so that slow dance later might look something more like this. So you're looking heels out and legs wide. Does that make sense? So that's where these are designed. There's one, some women really like to do like a Captain Morgan type of position. And I think what's nice about the Captain Morgan position is that you lock in your pelvis. So like if you have SI joint problems, or if you're getting some SI joint pain, sometimes it's nice to like stick a leg up. So now you've got that wide leg. You can even play with the position. You don't need to hold it up in the air like that, but you can, get it up on the bed, get it on the bench. And so you can play with your position here, be leaning on your partner, leaning on the bed, hanging onto the bar, whatever. And now you have that wide pelvic outlet, and then also playing with, you got your hip position. So you're like widening your hips as much as possible. You can play with these positions in sitting. So if you have an epidural and you're in early labor, than sitting more with like sitting more like this, like upright in the birthing seat, versus like later labor thinking more like this, sitting upright. So those are really the ways through it. The one position, the lap squat for late labor, that one's a little bit, Megan always loves demonstrating this one with me, although we don't have a good chair.
What is it? Oh, thank God.
So that one, what you do is you, so partners, you'd be sitting. So I would recommend trying this at home. It looks way scarier than what it is. But partners, you're gonna sit like kind of on the edge of the chair, and then pregnant women, you're gonna sit on their lap, and then all you do is open your legs, and then it seems scary, but you're gonna drop down lower. And you can adjust how low you go, but what's nice about that is it's a really big open to the pelvic outlet. So that might be, you know, like you're starting to hit 6, 7, 8 centimeters, like baby's dropping really, really low. That might be a nice way to kind of relieve some of that pressure in still that sitting position. So that's the one that I think is nice. If we're talking perineal tears, side lying is the position of the least incidence of perineal tears. We think about squatting like we've had conversations about like wanting to squat during delivery because you're like, oh, gravity, like tailbones free, here we go. That's actually the highest position for incidence of tearing. Right? You're
more pressure, gravity pushing down.
Yep, might be a little bit faster. Like labor might be a little bit faster. It's already a big stretch to your perineum. I mean, lots of women deliver in squatting, like it's not a bad position. It's just a different version of delivering like this. In dorsal lymphotomy is what that's called. But definitely something to think about. Lots of people like sitting on the commode. That's kind of another version of the lap squat because again, you don't have anything underneath your pelvis, so you don't have like a ball pushing back up against you. So it's just kind of a nice open space. The supported squat is nice too. If you're gonna
Oh.
This was really fun when we were both really pregnant. So just face that way. So I actually don't know if we've done this. So now just kind of squat into me. So something like this too, and then you can get that rocking back and forth, right? So let's look at my body position, right? So I'm in, like, you're not gonna be able to hold her like this, right? So like chest out really wide and then holding for that, right? So, and even like the doula was doing, like you could squat in this position too, right? So that's,
You want me to use my own legs?
so that's definitely something to think about. Lots of, I mean, we saw her like laboring in like a child's pose position. That's really great, like another good way to open the pelvis. So dabs, these are, like I said, when it isn't working, change it. This is it, right? So move through these different things. Don't feel like you have to come up with novel positions on your own. Like you can absolutely be using some of these techniques.
And maybe it isn't even, maybe it isn't even a position that we need to change. Maybe it's like, maybe they need a cold wash rag on their face. Maybe they need to suck on a popsicle. Maybe they need, a sip of Gatorade. Like maybe they need something else. We just delivered a gal that brought in, a whole box of popsicles when she showed up. And I think that's a great idea. Like if you know, like this is what I like, then bring that with you and we can put it in the freezer or the fridge or whatever and make it easier on yourself. Okay, so we're almost running out of time. So just briefly, what to pack. And then we're going to go over and tour the labor rooms so that you guys can check those out. Okay. So there's like a bazillion, lists on Pinterest that I'm sure you guys have already looked at and considered. I think really like first time moms always overpack, because you don't know what to bring. But think about it, like, especially if you're going to end up with an induction, like, you want something comfortable to labor in for maybe a couple of days. Or like if you bring like your one outfit that you really want to labor in and then your water breaks and now it's a big soggy mess, like now what's your backup plan? So like maybe bring like a couple outfits to labor in just in case it doesn't go quite as planned. you know, something that's comfortable. And honestly, like, you might start out thinking like, oh yeah, I'm gonna wear, you know, who knows, maybe you have a labor gown, or maybe you have shorts and a t-shirt or whatever you have, you know, and like one by one, every article of clothing is going to come off, because, you know, everybody's naked by the time they're having a baby. That's just the way that goes. You know, if you want to be in and out of the bathtub, some people want a bathing suit. Some people, you know, by the time they're like ready to have a baby, they're just like, I don't want anything on, and that's how that's going to go. But definitely like bring yourself a few options in case you're like having this slow induction and you're out walking the halls. You know, won't let you do that naked. So
I think the biggest thing is like in the shortest case scenario, you're going to be in the hospital for 24 hours. In the longest case scenario, you're going to be in the hospital for about 72 hours. So pack maybe for up to 72 hours, but like, it's not like your days in the hospital aren't spent doing a whole lot, right? So like you probably only need, like, you have what you labor in, and then you maybe have like the thing you change into next, and then you have that outfit that you're going to go home in, right? So it's not like you need a ton of clothes. I actually think on this list, mom's list is pretty good. That's like I think most of those things are pretty good. We do have lotion here, but if you have lotion, you don't need most of that stuff for baby. You need a car seat, and you need an outfit to go home. But they're going to be naked while they're here. I would bring diaper cream. That is something that we particularly don't have in our hospital. So I would bring that. And if you have a special baby blanket you wanna use, but otherwise we have blankets, we have wipes, we have lotion, we have diapers.
And we'll send you home with the extra diapers and wipes. And then we'll have receiving blankets here. So you just really need, you know, yeah.
I don't know, this is probably something just when I was growing up. Did you guys send them home with like a blue or a pink blanket or something like that?
We send them home with a blue or a pink t-shirt that says like, I made my entrance at Lake District Hospital or something like that. And they're just like a little tiny pink or a little tiny blue.
And then a little purple hat, right?
The hats are like pink and blue striped, little tiny hats. But if for some reason, like somebody doesn't, you know, it used to be like as soon as that baby was out, we had to get a t-shirt on them. And now everybody's like way more into skin to skin. And so sometimes it's like that t-shirt is forgotten. So like if it's forgotten, just be like, hey, can we get our blue t-shirt, or can we get our pink t-shirt? And somebody would be happy to get it for you. Other things like phone charger, camera, stuff like that. If you want to bring in your baby book, we can put footprints in it, you know, stuff like that if you guys want that.
When should you pack this?
I say 26 weeks, but this is coming from the lady that's had 2 preemie babies, right? So
I'm like packing on my way out the door, like because all my clothes were in the washer or the dryer, so.
I was like, are you allowed to do the wash for 30 weeks? Like,
well, it depends, right?
Yeah.
So like, yeah, I mean, like as long as like if your water breaks and it's not like brown tinged, then yeah, absolutely. You know, like we said, the clock is ticking, but it's not ticking that fast.
Yeah. I mean, if it was like your 7th baby, I'd be like, yeah, I probably wouldn't roll the dice and like have nothing packed, because that baby's gonna just, you know, slip out in the middle of the night and you're gonna have no time. You know, but if it's your first baby, like the chances that like, I mean, we can all hope that we're gonna have a 3-minute delivery and we're just gonna, you know, sneeze that baby right out, but that's probably not going to be the reality. I mean, I would
have a list, like have all the things you want to grab, like the bag, like have it all ready. So, yeah, but
I mean, you can get a diaper bag packed. I would get your car seat installed in the car, like get those things done, because that's pretty easy. You know, I always felt like packing my clothes was the last thing and the hardest thing, because like, but you know, by the end I only had 2 t-shirts that fit. So it was like one's in the wash and I'm wearing the other one.
And that's why I'm saying like you don't really need all that many clothes. Like I mean, even with a C-section, like as soon as I was able to move my legs, like I changed into like I bought like a nursing dress, like, and so it was super easy. And I think I brought 2 of those to the hospital, and then I had a robe like a soft robe that I put over, and then the clothes that I went home in. And so those first 2 things, like I wasn't wearing those at home, so I just like tossed them in the bag. So yeah, anything that you're not using regularly that you're just going to use at the hospital, I would throw it together. you know, again, like, but I'm also the person that like suddenly had to deliver a baby at 33 weeks that I had nothing packed.
A friend that had that happen too, just this last week, so.
Yeah.
Yeah.
So
It is always better to be prepared, like
Yeah.
over prepared than under prepared.
Yeah, I remember when we taught the two or three, well, last fall, I guess, when we were teaching this class, I had my bag packed for like 10 weeks already. And I was still 10 weeks out. Like I think I was only like 28 or 29 weeks, like when we were teaching this class. So, I mean, you know, somewhere in the middle, like know what you want, but there's a lot of stuff that we can give you too.
Like, you know, like all the things like, you know, wash your breast pump, like figure out how to use it, install your car seat, like the things that you can do ahead of time, you know, like do those things ahead of time because nobody wants to be figuring out how to install the car seat, you know, at the last
Holding
minute.
the
Like
baby.
for heaven's sakes, like set up the crib, like, you know, do the things that you can do ahead of time so that if you find out like tomorrow, like, oh my God, my blood pressure's elevated and you're flying me to Medford, like don't add more stress to an already stressful situation.
And maybe this is where it's like good to think about what you want for the outcome. Like, are you going to want diffuser and oils? Like, are you going to want, you know, like these like comfort measures? Like maybe those are really good things to have packed because if you're trying to throw together like clothes and the diaper bag and like a bag for dad and like our phones and chargers and all that, like those comfort items may fall to the wayside. And if you're really going to be depending on those or feel like you really needed those to help you, so that's something too. Like, my recommendation is just get it packed. Like everything that you can that you're not using consistently. But we've had two very different experiences. Megan usually goes past. I go way early. So
I don't want to get too excited because I know I'm going to go to 41 and a half weeks before I have a baby. Okay, so we're going to walk over and look at the hospital, the birthing rooms, and then we'll see you guys next week. So if you guys just want to take your stuff.
if anybody wants, I've got some more before we leave. Effective epidurals on the second stage of labor, just some research, and then some research on movement and positioning during labor. If you guys are interested, I'll set those out here. There's also water in the pitcher too, if you don't want tap water. Not sure what about.
Take some fruit.
Okay, well that's good. Yeah, so help yourself to the papers, you guys. Oh, I should take our online piece of it.
And so there's one of these wall plates in there because the doors are locked and you're gonna be like, oh my God, how do I get in? So you'll have to push the button and they'll let you in. And I guess now in the day of COVID, they'll be you might want to think about like a backup labor support person because they're gonna screen positive at the door and not be allowed in. So that's just like a good thing to consider ahead of time. Absolutely not. So we'll let you guys in and out. So this right here is the nursery. We
Come all the way in, yes.
hardly ever keep our babies in here unless they were sick or something. It's more than anything, it's a place that we store equipment and whatnot. We want our babies to remain long 24 hours a day. So that's kind of the expectation. Here's our little nurses station. And if we have patients back here, we'll usually have somebody here. If not, they might be out at that nurses station. Okay, so we'll go look into it. So, both of our labor rooms are actually full right now. So this is the room that we usually reserve for C-sections. So it looks a little different. So the rooms are pretty much set up the same. The biggest difference is that this C-section room doesn't have the jacuzzi tub. It has a walk-in shower. And that's just easier for moms when after C-section, they don't want to like drag their leg up over the side of a jacuzzi tub. So unfortunately, you won't get a look at the jacuzzi tub tonight, but the rooms are pretty big. In the labor rooms, there's like a bench underneath the window that dads can sleep on. But many dads tell us that it's the worst thing they've ever slept on. And so we're happy to bring in a cot for you to sleep on that's more comfortable. We have a newborn warmer in all the rooms. And if we needed to, we can resuscitate baby with the equipment on this. So if you see this in your room and it's turned on and it's warmed up, don't think that like, oh my gosh, they think that my baby's not gonna do well delivers. We get it ready for every single delivery just in case we need it. This over here is the fetal heart monitoring part. So when we talk about monitoring baby, right, that's gonna be these monitors on your belly monitoring baby's heart rate and your contractions. So when I say like, we don't want you to be hooked up to the monitor all night long, I don't want you to be like tethered to the bed in the monitor. Like, so don't let somebody tell you that that's the way it has to be. Like you can be on a yoga ball, you could be up walking around, there's options. So that's that. If you did have IV fluids, you would have to drag your IV pole around. But like I say, most moms are able to drink enough early in labor to stay hydrated. The windows are tinted, so you can see out, but nobody can see in. So I really like the windows open so I can see out. One of my friends delivered, you know, like hands and knees on the top of the bed. The windows were open. You know, not a care in the world. And the next day she went to breastfeed baby and she was like, do you think we should close those shades? And her husband was like, are you kidding me? Like you delivered butt naked on the top of this bed while the maintenance guy was trimming the bushes outside yesterday. And that wasn't a problem. But they are tinted so nobody can see in. Often the nurses are charting right here in the room. So don't be surprised with that. And right down the hallway are the doors into the operating room, so you can see those. And it was designed, you know, so that if we needed to take a mom to C-section urgently, across the hallway. There's an ice and water machine down the hallway, and then if you're a coffee drinker, just ask us to make a pot of coffee, and we're happy to make a pot of coffee and have it out there so that you know, don't have to go to the cafeteria or something like that to get coffee. Okay. If you want to bring popsicles or juice or snacks or whatever, we're happy to store them in the refrigerator or the freezer. So yeah, just
You can move your stuff into the closet here
Yeah.
too. Like all the
This-
rooms have
This is
closets.
like the least fancy of all 3 rooms, so you guys will be pleasantly surprised if you move into one of the other 2 rooms when you come in, but this is how it goes. The inn is full tonight, so. Okay, any questions?
So if you're having like a November baby, can you just bring Thanksgiving in? Or-
Yeah, we could. We do actually do like a fancy little stork dinner. So the night after you deliver, we set you up like a little candlelight dinner with sparkling cider and like a fancier menu. So you can do that one night while you're here. But so I can't remember if we talked about this the last time, but the restrictions for visitors during COVID. So while you're laboring, you can have 3 adult people. They have to be the same people. You know, it can't be like 3 come in and then they tap out and 3 new ones come in. The same 3 adults while you're laboring. And then after you deliver, only 1 person, and it has to be over 18, so no kids. Okay. But you could certainly have somebody drop Thanksgiving dinner at the nurse's station and we'll bring it on back.
All of it?
Well, I don't know if we're supposed to advertise it, but I think it's probably happened to text. Okay.
Like the champagne.
All right. Any questions? Okay. Well, we'll see you guys next week. Drive safe.
Thank you.
Yeah, you're welcome.